you can hear me, welcome to our live fertility Q&A. This is my first time doing this on Zoom, so hopefully all will go smoothly. I'll give people a few minutes to log on here from wherever you're logging on from. Hope you had a good Thursday. Hope some of you got out and enjoyed the nice weather out there. I am coming to you, full disclosure, from my basement, virtual background, so it doesn't look like this. But we're here tonight just to hear some of your questions, answer what's been going on, and what you'd like to know fertility-wise. Just to tell you a little bit about myself, my name is Dr. Kristen Wright. I'm the medical director of the Boston IVF Center in Bedford, New Hampshire. I've been practicing in New Hampshire since 2011. And the practice here has steadily grown, and we opened a full service IVF center in April of 2021. So we're able to provide full spectrum IVF services to patients in New Hampshire. We're the only center in the state. And I just want to give a little shout out to my team here in New Hampshire, since I wouldn't be able to do any of the things that I do without them. I have a wonderful nursing team, very caring professionals who talk to patients regularly. And if you're one of my patients, I'm sure you've worked closely with my nursing team. We also have a state-of-the-art IVF lab here in New Hampshire with a wonderful embryology team, very skilled personnel there. And then myself and Dr. Toth are the practitioners in the office, together with a physician assistant. So that's us. If you're one of our current patients, welcome. And if you are out there looking for help, then we're here for you. That's what we do. So with that, let me try to open a little chat box here. So I have some questions that were sent in before the webinar, so I'll start with those. And then feel free to put questions in the chat feature, I think is how you do that. And they'll pop up to me, and we'll get to as many questions as we can here. So one of the first questions that was sent in asked, do elevated hormone levels in women cause cancer? I've known women who've been diagnosed after IVF. So the answer to this question is probably not. There's theoretical concerns that the increased hormones that you see during an IVF cycle could increase risks for things like breast and ovarian cancer, since both the breast and the ovary are responsive to hormones. But there have been a number of studies that have been done looking at that, and some of those studies don't suggest a significantly increased risk. What is challenging about interpreting that data is that infertility actually in and of itself can increase the risk of both breast and ovarian cancer. Pregnancy is actually protective against those two cancers, which a lot of people don't realize. So it can be a challenging thing to study from that perspective. I would say that if you're concerned about an increased risk of breast or ovarian cancer, one thing that you can do that pretty dramatically decreases the risk of ovarian cancer is to be on birth control pills, which I know sounds funny, but we've known for a long time that birth control pills significantly reduce the risk of developing ovarian cancer, presumably because they keep the activity in the ovary quiet. So if you are someone who's gone through IVF in the past, for example, when you're between pregnancies or when you've completed your pregnancies, you can talk to your practitioner and see if going on birth control pills at that point would be something that would make sense for you to do. And then we do obviously recommend routine screening with mammography for anybody for breast cancer. Fortunately, that there's good screening modalities that are available now. So probably not an increased risk, but if you're concerned, those are some things that you can consider. Next question is, what are my options for premature ovarian failure? So premature ovarian failure also is sometimes referred to as premature ovarian insufficiency. And basically what that means is that someone has gone through an early menopause before the age of 40. So women were born with a set number of eggs in our ovaries. As we get older, the number of the eggs in the ovaries will go down. Eventually, they'll completely run out, and that's when you go through a menopause and the menses. You stop getting your period at that point. For average age of menopause is about 52. About 1% of the population will go through menopause before the age of 40. That's what we term premature ovarian failure or premature ovarian insufficiency. We can still help women with that condition to become pregnant. The main issue there is that there are not eggs to work with. So the only way we can help you to achieve a pregnancy would be to use donor eggs, but that is a good option for women with premature ovarian insufficiency. Using donor eggs has gotten a lot easier than it was about a decade or so ago because we have an ability to freeze eggs now. So there's 3 egg banks that we work closely with at Boston IVF. You can work with any of those banks. There's a number of donors that are available, and you're able to go online and view profiles of the donor and select a lot of eggs that you would like, which would then get shipped to us. And then you would need to undergo some hormones to make the uterus ready for pregnancy. The eggs would get thawed at the appropriate point in your cycle, put together with sperm, the partner sperm or donor sperm, and then resulting embryo would be transferred back to your uterus. Women are able to achieve pregnancy this way even after they've gone through a complete menopause. You would need to take hormones through the first 10 weeks of the pregnancy. At 10 weeks, the placenta is fully formed, and at that point, the placenta produces all of the hormones that are necessary to support the pregnancy. So further medications beyond the 10-week mark are not required. The pregnancy would just be self-sustaining at that point. Next question. What is the reason someone would do a medicated versus a natural cycle? So this is presumably referring to frozen embryo transfer cycles. So there's 2 basic ways we can do a frozen embryo transfer. Most commonly, we do what's called a medicated cycle, which means that we give you estrogen, which helps the lining of the uterus to develop. And then once the lining of the uterus is developed appropriately, you would start the second hormone, which is called progesterone. The advantage of the medicated cycle is that your body doesn't need to do anything. We'd be giving you all of the hormones that are necessary to support the pregnancy. It's very easy to schedule medicated cycles because there's a lot of flexibility and timing in terms of when we can actually schedule the embryo transfer procedure. It's also pretty well mapped out as far as what will happen when. Usually only 1 ultrasound would be required during the cycle to ensure that the lining looks okay. And then the embryo transfer would get scheduled at that time. Medicated cycles are best for women who don't ovulate on their own, or women who are older, especially women who've gone through like a premature ovarian failure, or generally for women over the age of 38. I recommend a medicated cycle just because sometimes the ovaries aren't quite making enough hormones to support a pregnancy in that case. So that's the reason to choose a medicated cycle. The second option is to do a natural cycle. So a woman's body prepares for pregnancy every month, and we can take advantage of that by timing the embryo transfer at the appropriate point in a woman's cycle. Doing a natural cycle relies on a woman having a normal ovulatory cycle. So if someone doesn't have a normal ovulatory cycle, then it's not as good an option. There is on average more monitoring involved with the natural cycle because we do need to precisely pinpoint when you're ready to ovulate so that the embryo transfer happens at the appropriate point in the cycle. And scheduling for that is not flexible. So your body is ready when your body is ready. And we can't really move the date for timing of the transfer in that case. And sometimes we need to use like birth control pills to manipulate people's cycles a little bit if we're planning to do a natural cycle, just so that we make sure we have an embryology team available at the time that you're going to be ready for your transfer. The main advantage of the natural cycle, and the thing that patients like about it, is that it does avoid intramuscular progesterone injections. So unfortunately, with a medicated cycle, the estrogen medication is oral, but the progesterone medication is an injectable medication and can be uncomfortable. So the natural cycle does avoid that medication, which is definitely a nice benefit. So next question says, what is the reason someone, nope, sorry, I already did that one. So next question is, how much emphasis should be put on embryo grading if embryos are euploid? So there's different ways that we can select the embryos that are best for transfer. For all embryos, we will assign what's called a morphology score, which is basically just a beauty contest. So we look at the embryo in the Petri dish and we grade the appearance of the two cell lines in that embryo. And we give it a letter score, A to C. We like to see A's and B's in terms of quality. So that's part of how we score the embryos. The other thing that we look at with morphology scoring is the rate at which the embryo develops. There are 6 stages. Sorry, my nose is running here. There are 6 stages of embryo development. We generally freeze embryos at stage 3 and higher. And we assess embryos throughout the day on day 5 of embryo culture, day 6 of embryo culture, and day 7 of embryo culture after an egg retrieval procedure. So the rate at which they develop also tells us something about the ability of that embryo to implant it to make a normal pregnancy. Morphology is unfortunately pretty poorly predictive of implantation, and we see all the time good quality embryos that don't make successful pregnancies. There are times we see embryos that really don't look so hot that perk up and make a successful pregnancy. So it's not super predictive. The difference between a higher scoring embryo and a lower scoring embryo is often just a few percentage points. The other way that we can assess embryos is to do something called PGT testing. That involves biopsying the embryos to confirm which embryos have chromosome problems and which don't. That testing is especially helpful for women over the age of 38 because as women get older, a higher proportion of their eggs are expected to have random chromosome abnormalities. We can't tell that just by looking at the embryo, and morphology score does not predict that in an embryo. The best way to assess that would be to biopsy the embryo and perform PGT testing. And that would tell us whether the embryo is euploid, which means that it's chromosomally normal, or aneuploid, which means that it's chromosomally not normal. Embryos that are euploid have much higher implantation rates, obviously, since most aneuploid embryos do not make successful pregnancies. So the PGT testing is much more predictive of embryo viability and embryo quality than the morphology score. But we do look at both of those things. PGT testing is definitely very helpful for older patients. It's not as helpful for our younger patients. So often we are actually not performing PGT testing in our younger patients simply because it doesn't help overall long-term outcomes. And it takes longer to do PGT testing. It also costs more money to do PGT testing, and that testing is often not covered by the insurance companies. All right, so next question. How long do you typically wait after delivery until you start trying for baby number 2? Age isn't on my side, and we had our first baby in July, and this patient noted that this was a result of IUI number 2 for her, thanks to your team. So thank you, we're very happy. I can't see who this is, but congratulations if I haven't talked to you already on your baby. As far as the next baby, ACOG, the American College of Obstetrics and Gynecologists, does recommend now to wait 6 months after your baby is born to get pregnant again. The reason for that recommendation is that if you space the pregnancies too closely, there is an increased risk of developing complications that can lead to preterm birth. It's also a risk factor for having growth restrictions, so babies may not grow as well in that second pregnancy if it's spaced too closely to the first pregnancy. They also note in that same recommendation that kind of optimal interpregnancy interval would be to wait until the baby is 18 months before having your next baby. But the difference there is relatively small. So if you have your next baby when your baby is 6 months versus 18 months, it's a pretty minimal increased risk there. And so if you're someone who's young and you want to wait the 18 months, that's certainly reasonable for you to do. I can tell you that most patients who've been through fertility treatment, they're often older, they recognize that it might take a little bit of time to become pregnant, their first treatment might not work right away. So in those cases, certainly trying for the next pregnancy after 6 months is very reasonable to do, and we'd certainly support that. If someone wanted to space it closer than 6 months, then we'd have a careful conversation about the risks involved, and just make sure that that's an appropriate choice for you. So that's certainly a discussion that we can have for you. But this baby was born in July. I'd say, certainly fine to come back at this point. It would take some time to update testing before we'd be starting treatment again anyway. So you'd be at the 6-month mark at that time. And then I have a couple questions about PGT testing. So someone is asking whether PGT testing is helpful for male factor and whether it's necessary in women who have PCOS. The major indication for PGT testing is age. So we know that, as I mentioned earlier, as women get older, a higher proportion of their eggs have chromosome abnormalities, and screening embryos in that case certainly improves pregnancy rates, and it typically would shorten time to successful pregnancy because we're not transferring spending a bunch of time transferring abnormal embryos. Severe male factor infertility, so that's usually counts less than 1 million, may be associated with an increased risk of chromosome abnormalities in the sperm. So you can consider doing PGT testing in that case, although age is certainly much more predictive than quality of sperm in terms of risk of chromosome abnormalities and benefit of PGT-A testing. And then same story with PCOS. So PCOS, there may be a slight increased risk of chromosome abnormalities. We typically see in women with PCOS more variability in embryo quality. So those morphology scores that I was talking about earlier. Typically a woman with PCOS at the time of IVF will make more eggs than a woman without PCOS, but we'll see more variability in embryo development and in embryo quality. So they usually still do okay. We usually still end up with about the same number of embryos, but you start with a higher number of eggs and you see more drop off in embryo development, typically in women with PCOS. The other category of people that really benefit from PGT-A testing are couples who've had recurrent miscarriages, especially if a woman is older or if we know that some of those losses have been due to chromosome abnormalities. That is the most common cause for a miscarriage. About 60% of pregnancy losses are related to chromosome abnormalities. So if we perform IVF and we screen those embryos, then we screen out those embryos and don't spend time transferring them, and that would reduce risk of subsequent miscarriage. So the two big categories of people that should consider PGT-A testing: women over the age of 35 to 38, and women with recurrent miscarriages. All right, I'm going to go to some of the live questions that are coming in now. So this is a question: can you talk about working out while starting IVF? Certain workouts you should avoid or should start doing. So in general, I think that exercise is a healthy and an important thing to do. So if you are already exercising, good job, keep doing that. And staying active through the pregnancy is also certainly usually safe and a healthy thing for you to do. The one thing that you'll need to avoid during the IVF cycle is real vigorous activity. So that's things like running, high impact aerobics, anything that's jostling your pelvis around a lot. The reason for that is that at the time of IVF, your ovaries are going to become enlarged from the medications, and most women can feel that as crampy, bloaty discomfort. And there's a rare risk of something called an ovarian torsion, which is where an ovary twists on itself. It's rare that happens, but it's a surgical emergency when it does. And real intense activity can increase the risk of a torsion. So low impact things are fine: walking, riding a stationary bike, those things are all okay to do. And then in terms of exercise, in general, when you're trying to conceive and while you're pregnant, I recommend to take it down one level of intensity from whatever it is that you're normally doing. So if you're normally a very active person, again, totally fine for you to continue to be an active person, but you don't necessarily want to increase the amount of activity that you're doing or increase the duration that you're exercising. I would think more about taking it down maybe one notch from what you normally do, maybe shortening the duration of things a little bit, just to not overstress your body too much while you're going through all of this. But definitely fine and appropriate to continue to exercise. your embryo is not going to fall out if you exercise. A lot of people worry about that. That's not a thing. That's not something that would happen. So hopefully that answers that question. And then, so there's a question here. Please explain how you manage IVF with patients who have endometriosis and how do you limit their exposure to estradiol? So endometriosis is a condition where tissue that's supposed to be just on the inside of the uterus is growing outside of the uterus. That causes scar tissue to form and also causes an inflammatory response, which can often cause pain, typically with the menstrual cycle and sometimes at other points in the cycle as well. Endometriosis primarily causes infertility through a mechanical means. So all of that scar tissue that's inside the pelvis just means that the egg often isn't making it into the fallopian tube because it's just being ovulated into a bunch of scar tissue. Even when the tubes are open, that can be the case. So the most successful way to treat infertility that's related to endometriosis is to do IVF, since we would be bypassing the scar tissue in that case. The protocols that we would usually use for women with endometriosis typically will involve Lupron, and that helps to suppress the endometriosis, the hormones that are stimulating the endometriosis. So a long Lupron protocol would be kind of a standard protocol that we would use for someone with significant endometriosis. And then as far as limiting exposure to estradiol, there is a medication we sometimes use called letrozole that can also be used to decrease circulating estradiol levels. Letrozole can be used concurrently with an IVF cycle. There's not usually an advantage to doing that though. But if a woman is doing IUI treatment and they have endometriosis, my choice medication for that would be letrozole because it lowers circulating estradiol levels. And sometimes women with endometriosis require more significant suppression. So we can do between 1 and 3 months of significant suppression with Depo-Lupron, which will basically completely shut down the hormones and put someone into a temporary menopause state for a couple of months. And that does really quiet down the endometriosis. Most patients don't need that. So most patients, standard IVF protocols that involve Lupron will help, and they'll be able to conceive successfully without needing to do anything stronger. So I hope that answers that. And then I have a question here. Is it possible to become pregnant with an AMH of 1.7? So yes, it's actually possible to become pregnant with an AMH of basically anything. What the AMH tells us is how many eggs are in the ovaries. So AMH is actually, and that's part of the ovarian aging process. As women get older, the number of eggs in the ovaries will decline as a function of age, and then AMH level will come down. So an AMH of less than 1.0 is considered as diminished, and then less than 0.7 would be considered significantly diminished. The AMH is actually pretty poorly predictive of fertility. However, it is very predictive of what type of response we'd expect to IVF medications, especially to IVF medications. So the higher your AMH is, the more robust a response we would expect to IVF, the more eggs we would expect to work with in an IVF cycle. Someone with an AMH of 1.7, I would expect to have a good prognosis. We would put you on, reasonably higher doses. That AMH isn't super high, so we wouldn't be so worried about hyperstimulation or overstimulation in that case. So we put you on a high-ish dose of medications, but I would expect an appropriate response with that AMH. For younger patients, anything above 6 to 8 eggs is a pretty good place to be in terms of pregnancy rate. So hopefully you'd be able to achieve that. All right, next question to mom, hopefully. Household here. I'm 39, she's 38. Should we both be tested to see who's best for fertility? And thank you for doing this tonight. So yes, I think if you're both willing to carry a pregnancy, doing testing to see where your ovarian reserve is at would be helpful to see. You're pretty close in age, so the fertility testing would be helpful in determining which one of you is more fertile. Obviously, it depends on what your family goals are here. So sometimes with same-sex couples, really only one person is interested in carrying the pregnancy. In that case, we will most commonly perform donor sperm inseminations or do IVF on that patient. There is also the option of something called reciprocal IVF, which sometimes we do for medical reasons. Other times we do it just because that's how people want to grow their family. So reciprocal IVF, or partner-assisted reproduction, is the other term we use for that, is when one person donates an egg to the other person and then the other person actually carries the pregnancy. It's more complicated to do that from a medical perspective, but it's often very successful. So again, if there's a medical reason to do that, if one of you doesn't want to carry the pregnancy but has a lot of eggs, then that would be an option to consider. So lots of things to consider, but yes, starting with testing would certainly be helpful in giving you some more guidance there as far as what the best approach would be for you. So next question's challenging. It says, for a woman with a low AMH of 0.5 and an antral follicle count of only 2, would you recommend IUI or IVF? So the answer is that this is somewhat dependent upon age, but this woman has, this testing indicates a lower ovarian reserve, so a lower number of eggs in the ovaries. Assuming that she is still ovulating and having a regular cycle, we would expect success rates with IUI to be the same as what they would be even with a normal ovarian reserve, because with IUI, we're only hoping or expecting the release of 1 to 2 eggs, and that would be expected to be achieved with this testing. Success rates with IUI vary a lot based on age. It's definitely a good option for women who are under the age of 35. We see a 12 to 15% chance of successful pregnancy with IUI per cycle in our younger patients. As you get older, those numbers go down. Success rates with IUI after the age of 38 are less than 10%. And generally, because of that, we will skip over that more conservative treatment and go to IVF in those patients. The concern with the lower ovarian reserve is that we would expect to have fewer eggs to work with. And with these numbers, you may or may not respond appropriately to IVF medications. We usually like to see at least 3 follicles developing on the ultrasound to move forward with IVF. In women with lower ovarian reserve, sometimes we don't have that. So if we only have 1 or 2 eggs developing with IVF, we can still do it, but the prognosis, the chance of being successful with that treatment is just lower when we have fewer eggs to work with. Of all the eggs that we retrieve at the time of IVF, not all of the eggs will fertilize together with the sperm. Not all embryos will continue to grow and divide and culture. Not all embryos will be normal if we test them for PGT with PGT testing, and not all PGT tested normal embryos will make a successful pregnancy. So we always see some drop off in the numbers as things go along. That said, in a younger patient, quality of eggs is most dictated by age. So even if we get a lower egg yield, we can still see successful pregnancies at a reasonable rate in younger patients with lower ovarian reserve. As you get older, prognosis just tends to be a little bit more poor just because quality of the eggs will go down with age. And when you're working with a limited number of poor quality eggs, just a lower chance of success in those patients. So certainly seeing a fertility specialist, if you're not already, sooner rather than later would be a good idea in this case. All right, I just want to make sure I answered all the questions that were submitted before. So one question, is it possible to get pregnant when an individual has 1 fallopian tube and 1 ovary? And the answer is yes, especially if both the ovary and the fallopian tube are on the same side, which would usually be the case. So usually if someone is missing both an ovary and the fallopian tube, it means that someone took them out on one side, but the other side is still okay. Typically, fertility is about normal in those patients. The one thing to be concerned about is that ovarian aging, especially later in the reproductive years, will happen a little bit faster because there's only 1 ovary, so there's fewer eggs available. So in that case, being proactive if you're not becoming pregnant, right, on your own, and to make sure that there's nothing else going on, and to potentially consider fertility treatment sooner rather than later would be recommended. But in general, yes, it is still possible to conceive. It's also possible to conceive. There have been case reports of this. If you have an ovary on one side and a fallopian tube on the other side, pregnancy can actually still occur. It's less likely to occur because the egg has to travel further to get to that other fallopian tube, but just an interesting little fact that that can also occur even if they're on opposite sides. I have a question here that I wanted to address. It says, I feel like infertility is taking a huge toll on our sex life. How do we keep it alive? And I just want to acknowledge that this is a really common problem, a really common way to feel in women who are going through experiencing infertility, trying to have a baby. Sex becomes a chore. You know, we have to do it tonight. You know, we're not in the mood tonight. I'm ovulating, so we have to have relations. So it's very common for that to start to be frustrating and to start to affect the relationship. So a couple of suggestions. Number one, the window in which it takes to conceive is wider than you might think that it is. So I know we often get very clinical and we say, you know, the day that an ovulation predictor kit turns positive in the following day, those are your fertile days. Make sure you're having sex during that time. But the other way you can approach it, especially if you've been tracking your cycles for a few months and you have a general understanding of when you ovulate, you don't have to do ovulation predictor kits every day. You can try to have relations about every other day during that fertile window, whenever it feels right to you, whenever you're in the mood to do so. And that's probably going to give you about the same chance of pregnancy as being really regimented and doing things like ovulation predictor kits and making it you know, feel more clinical. The other thing that's often helpful is in these cases is to do IUI treatment. IUI treatment is it's pretty low risk from a medical perspective. So an IUI involves getting a sperm sample on the day that a woman's ready to ovulate. So we'd usually monitor her to determine exactly when she's ready to ovulate. And then on that day, get a sperm sample from the male partner, and then do an artificial insemination where we're placing the sperm directly into the uterus. That does improve the odds of conceiving over just trying on your own. But it also often just takes the stress off of the relationship because you know that you will have had a well-timed IUI at the right point in your cycle. You can continue to have sex whenever you want to while you're doing an IUI cycle, but that way it can happen when you're in the mood and when you want to have sex, as opposed to it having to happen on that specific day. So I do find that often helps to take the stress off of the relationship. So if you're finding that that's really bothering you, you know, that's certainly a reasonable thing to consider, because obviously your relationship and your sex life is important. All right, so another question I have here that was sent in earlier. How many rounds of IVF do you do before you tell the patient it's time to rethink new treatments? The answer to this question is it depends on how IVF is going. So if we've done an IVF cycle and we've gotten good embryos that were produced, but a pregnancy did not occur, usually we would try again and get a new batch of embryos, because most of the time when embryos aren't taking, it's related to the embryo and we just need to find the right embryo for you. So success rates, as long as we're getting embryos with IVF, stays about the same over the course of about 4 IVF cycles. If you're not pregnant after 4 cycles, pregnancy can still occur, but your rates do start to go down at that time. That said, I've seen pregnancies even with the 6th, 7th IVF cycles, they do happen, but you start to get a little bit more lower success rates at that point. On the other hand, if you're not getting embryos at the time of IVF, so if you're someone with very low ovarian reserve, someone who's older, and we're not getting a good response to IVF medications, and we're not getting to having embryos to either test or to transfer back to the uterus, then IVF isn't helping you much. So in those cases, we will usually recommend to move on to a different treatment, often donor eggs in that case. If you just have one cycle that hasn't gone well, we'll often try again, and we can change IVF protocols and try different things to try to maximize the response. But if you've had 2 poor cycles with low response or no embryos, then it is time to start thinking about other treatment options at that point. And then another question that was sent in kind of on a similar line, how many IUIs do you recommend before IVF? The answer to this is it depends on age. For women under the age of 37, it's usually most cost effective to do 3 IUIs, and then if not successful at that point, go on to IVF. The standard of care many years ago was to do 6 IUIs prior to IVF, but there have been studies that have been done looking at time to successful pregnancy and cost effectiveness. Actually, one of those studies was performed by Boston IVF many years ago. And that study showed that it's best to move on after 3 unsuccessful IUIs. So usually our plan, if we're starting with IUI treatment, would be to kind of regroup if you're not successful after 3 cycles and have a conversation at that point about IVF. Of course, you don't have to go on to IVF at that point if you don't want to, but certainly would be reasonable and recommended to consider that option at that point. For women, so that's for our younger patients. For women who are over the age of 38, as I mentioned earlier, pregnancy rates with IUI in our older patients is less than 10% generally per cycle. So we will often skip IUI treatment at that point and recommend to move directly to IVF, simply because time is not so much on your side if you're over the age of 38, even with IVF. So we often will not do IUIs for patients over the age of 38. The other situations in which we wouldn't recommend IUI, if there's tubal disease, then IUI is not going to perform well because IUI relies on having the fallopian tubes be open. If sperm samples are very poor, then IUI would not be recommended. And then in a younger patient with lower ovarian reserve, it's important to have a thoughtful conversation about the time that it will take to do the 3 IUIs and then move on to IVF. Sometimes the ovarian reserve will decline during that time, so that's something to consider. And then finally, ultimate family size goals are important in making this decision too. IUI will help you to get pregnant with that next pregnancy, but it won't do anything to preserve your fertility going forward. So if your goal is to have more than 1 child, IVF often helps you to accomplish that because you'd be able to freeze any extra embryos that you have. Frozen embryos can stay frozen for many years, so you can come back if you'd like down the line to grow your family, and those embryos will be frozen in time in terms of age of the eggs. So especially if someone is in their mid to late 30s, 35, 36, and they're considering IUI versus IVF, that's something to think about, because if you're 35, 36 and your goal is 2 kids, you might want to skip that IUI option and go to IVF. So, obviously we'd have a conversation about that and decide what's right for you. And then the last question that I wanted to address that was sent in advance relates to Lovenox and whether that's helpful in women who've had miscarriages with frozen embryo transfers. This is pretty controversial. There do appear to be a subset of women with recurrent pregnancy loss that might benefit from Lovenox. Certainly we know that anybody who has positive what's called antiphospholipid antibodies, which is a blood test that we'll usually do for women who've had 2 or more miscarriages. We know that those patients definitely benefit from Lovenox during pregnancy, and that will improve their likelihood of carrying the pregnancy. And if we see the other type of testing we can do is thrombophilia testing. So thrombophilia testing is looking for markers in the blood that increase risk of forming blood clots, which many people have. If you have evidence of those and you've had a couple of miscarriages, then sometimes using Lovenox in those patients will improve the ability to carry the pregnancy. The reason it's controversial is that there's not as much data to support that in women who, there's definitely data to support it in women who have antiphospholipid antibodies. There's less data, although there is some, in women who have thrombophilia markers that are positive. So we'd need to look at what markers are positive, what the pregnancy history is, and then make a thoughtful decision about whether or not to do the Lovenox. Lovenox isn't a benign drug, it's a powerful anticoagulant. So there's increased bleeding risk if you're taking Lovenox. So if you're taking it during a pregnancy, sometimes we'll see hematomas form behind the placenta. If you were, God forbid, in an accident or something, it would take longer to stop bleeding because you're using a powerful anticoagulant. So it's not a drug that we use willy-nilly, but it is something that can be helpful, especially in some of our more challenging patients who are having losses. So definitely something to consider. All right. Next live question here is chronic hepatitis B. Is a chronic hepatitis B patient eligible for IVF? So generally speaking, yes. We would want you to be medically cleared before starting an IVF cycle. So we would need to see whoever's managing your hepatitis B, make sure that it's under control, that your liver is functioning well enough to be okay during a pregnancy. But as long as that is okay, and the physician who's managing that disease feels like it's reasonable for you to be pregnant, pregnancy doesn't usually exacerbate that condition. There is some risk of transmission of hepatitis B to the baby, but we can usually prevent that from happening by vaccinating the newborn at birth. So they would receive medications at the time of delivery, and that's usually effective, especially if the viral load is low prior to starting the IVF cycle. So it wouldn't be considered a contraindication. We would just want to work with whoever is also managing that disease with you to make sure that it's safe and appropriate for you to do. So next question, for a woman in her 40s with nonstop uterine bleeding, what is the cause? Well, that should be evaluated because there are a few different things that can cause that. There's mention of hyperplastic polyps with this question. And polyps can definitely cause heavy vaginal bleeding. They can cause irregular bleeding. Usually the treatment of that is pretty straightforward. So doing a hysteroscopy procedure, which is a minor outpatient surgical procedure to remove the polyps, will generally correct that pretty quickly. So if that's what's going on for you, then that type of hysteroscopy procedure would be recommended. If they're truly hyperplastic, that means that there are some cellular changes happening within the polyp that can over time lead to like a uterine cancer. Then that would sometimes need to be treated with some sort of progesterone. That medication will help to suppress further hyperplasia and is often successful in clearing those types of abnormal cells. But if there's true hyperplasia present in the uterus, that's something that should certainly be addressed and treated. There's lots of causes of uterine bleeding. Fibroids is another cause. Sometimes there's hormonal reasons. And it depends on what the goals are. If the goals are pregnancy, then obviously anything structural should be addressed. If a woman has completed childbearing, removing the uterus or doing some sort of hormonal suppression will often be effective. So next live question, I have read mixed reviews on PGT-A testing and most recently read that there's no increased evidence of its helpfulness. The ACOG website states data has been inconsistent regarding clinical utility. ASRM does not currently routinely recommend use of PGT to all infertile women. So that is true. Those are the statements from ACOG and from ASRM. The PGT story, it's a complicated story because the way that we use PGT-A testing has changed and evolved. The platforms have gotten better in terms of the accuracy of the testing, and that's really changed a lot over the course of the last 10 years. So the platforms that we have are much more robust. They give us more accurate information. It's important to understand that they don't give us perfectly accurate information. So one of the big risks of doing PGT testing is that it's not a perfect test. We could call a normal embryo abnormal or vice versa. PGT, what we've learned over the last 10 years or so is that PGT tends to overcall abnormal embryos. So we might screen out embryos that actually would have been okay if we had transferred them. And there's a variety of reasons for that I won't get into. But that's important for you to understand if you choose to do the PGT-A testing. The main benefits to PGT are for women who are over the age of 38. So at Boston IVF, we looked at our own data a few years ago and looked at time to successful pregnancy and overall odds of achieving pregnancy. And we do successfully shorten time to successful pregnancy in women who are over the age of 38 if we use PGT testing. We do not successfully shorten time to successful pregnancy in women who are under the age of 38 if we do that PGT testing. So it's most helpful in those patients who are over 38. The other big advantage of PGT testing is that it allows us to more confidently transfer one embryo back to the uterus, because as women get older, a higher proportion of their embryos are expected to have random chromosome errors. We would often, before PGT testing was available, we would transfer multiple embryos back to the uterus to try to achieve a pregnancy, because we know there was a high chance that one or more of them would be abnormal. But that's, it's Russian roulette in a way, because it's possible that all of those embryos would be normal and result in a multiple birth pregnancy. And twins in general long-term do well, but they are higher risk pregnancies, including a higher risk of losing the pregnancy or preterm birth. And that can sometimes lead to lifelong problems, handicaps, or even death of the baby. So our goal is one baby at a time, just because that's the safest way to have your babies. And PGT-A testing does allow us to do that, as I said, more confidently. We also reduce miscarriage risk with PGT testing, and that's especially important in women who are over the age of 38, because it takes time to diagnose a miscarriage. By the time you get pregnant, realize that the pregnancy is not successful, treat that and allow the miscarriage to resolve. And then we usually have you wait one normal menstrual cycle. It ends up being about 6 months if you have a miscarriage before you'd be able to resume more treatment. And for a woman who's under the age of 38, that stings. I mean, it's hard to go through a miscarriage, but the time factor isn't as important. In our older patients, that time factor does start to be pretty important in terms of the odds of the next cycle working, because we know that fertility is going down every month as a function of age. So it's definitely controversial. I would say our general approach at Boston IVF, we do perform and recommend PGT testing for many women who are over the age of 38. If you're under the age of 38, especially 35, it does start to be pretty elective. And I don't strongly recommend it at all in women who are under the age of 35. In fact, I would tell you that it's pretty elective. You can do it if you want to, reduces miscarriage risk a little bit, but there aren't huge benefits there in terms of time to successful pregnancy and odds of becoming pregnant. So I'm sure we'll continue to see this testing evolve. Hopefully it will only get better with time. That's the hope. All right, next question. For a woman over 40, when would you suggest someone use their frozen eggs versus continuing to do egg retrievals? So that kind of depends on what type of response we're expecting with egg retrievals. So what the ovarian reserve testing looks like, if it's good and healthy and there's good numbers of eggs to work with, and doing egg retrievals would be expected to hopefully yield some usable embryos. If ovarian reserve testing is low, then prognosis with IVF is not going to be as good. And using frozen eggs, if they were assuming they were frozen earlier in their reproductive years, would be expected to be more successful. So success rates with frozen eggs really depends upon the age at which they were frozen. And the younger the better to a point in terms of odds of being successful with those. But I have women who approach this lots of different ways, and it depends on what your family size goals are. So that would be another thing to think about and have a conversation about, as far as what's important to you in terms of ultimate family size goals. All right, next question. If I'm taking an ovulation test and seeing a positive result, but not becoming pregnant, what would you recommend for first steps with Boston IVF? So if you are having a regular period and your ovulation predictor tests are turning positive, you can say pretty confidently that you're ovulating. And so that's not the problem, but there certainly could be something else going on. So having a full fertility evaluation would be recommended, assuming that you've been trying for at least a year if you're under the age of 35, or at least 6 months if you're over the age of 35. That's the point at which we would recommend a fertility evaluation. The times when you don't need to wait that time of trying on your own is if you are not ovulating, then you can come straight in, because we can help you to ovulate pretty easily, and you don't need to spend a year not ovulating, because you're not going to get pregnant if you're not ovulating. But if you are ovulating and there's no other obvious things going on with your history, trying on your own first certainly would be recommended. If that's not successful, first steps when you get to us would be to do a full fertility evaluation. there's a number of different tests that we would do. For the male partner, we would do a semen analysis test to ensure that there's adequate sperm. If sperm counts are low, treatment with IUI or with IVF would often be recommended. And then the female factors that we would think about, we would want to check the anatomy. So want to make sure that your fallopian tubes are open. A blockage in the fallopian tubes is a good reason for not becoming pregnant. And in that case, usually IVF would be recommended to bypass that blockage. There could be other structural factors like fibroids or polyps on the inside of the uterus that may need to be treated surgically. And then we would also usually do hormone testing to see where you're at in the ovarian aging process. As I said, that's not perfectly predictive of whether or not you'll get pregnant, but definitely helps us to decide which medications and treatments would be best for you to use. We'd also often rule out problems with the thyroid or the prolactin hormone. That's all done through blood testing. So a fertility evaluation, if you're ovulating on your own and you've been trying for a year, if you're under the age of 35, or for 6 months, if you're over the age of 35, definitely time to see someone and to do a fertility evaluation. All right, I can scroll, I can scroll. All right, all right, let's see what we have here. All right, so someone's saying I had an FET done 6 days ago. Do you think a home-based pregnancy test will be able to detect it? Also, I did yoga on the first day after FET, and I feel nervous. That was not the right decision, just thinking of what maximizes my implantation chances. Don't worry about the yoga, that's okay. Your embryo didn't fall out with the yoga, and there aren't activity restrictions with the frozen embryo transfer procedure. We're not worried about that torsion risk that I was mentioning earlier. The ovaries aren't enlarged. So it's okay that you did yoga. The cycle will work or will not work, but it's not gonna relate to what you did for activity there. So we tell you not to do the home-based pregnancy tests after IVF. Many people do, but you have to be a little bit careful there because we often will use HCG hormones to trigger ovulation, and HCG hormone levels will falsely turn a pregnancy test positive. So if you used a trigger with your cycles, you might see a false positive there. And then the urinary kits aren't as accurate as the blood test kits. So if the HCG level is really low, for example, the urinary kit won't pick it up. In general, home pregnancy test will reliably turn positive around the time of missed menses, which is about, assuming it was a day 5 embryo that was transferred, that's about 10 days after the transfer that we would schedule that pregnancy test. I'd recommend you just do the blood test since it's going to give us the most information. But a urinary kit would be expected to turn positive around that time. But again, we're usually scheduling a blood test as soon as we can because we know that you want to know the results from that. So recommend to just come in for your blood test, but about 10 days after the transfer is when we'd expect to see hopefully a positive for you. So I hope that's what happens for you. So this is just getting started with our fertility journey. Our first appointment with Boston IVF is in January. What should we expect? Good question. So I mentioned earlier some of the testing that will usually be recommended. At the first visit, you can expect us to take a detailed history, including medical history, talk to you about your medications, also talk to you about your lifestyle, make sure you're taking a prenatal vitamin, make sure you're not doing toxic things like smoking cigarettes or other things that might reduce your chances for infertility. So we'll talk about all of that. And then we may get some clues into your infertility just by talking to you. We may not know and just need to do the testing. But either way, the next step would be to proceed with fertility testing to see exactly what's going on. In addition to that, so the fertility testing for a woman would usually involve doing lab work and ultrasound on day 3 of the menstrual cycle. That's where we measure those reproductive hormones to see what the ovarian reserve looks like. And then the transvaginal ultrasound will look at, make sure there's nothing structural going on like fibroids or cysts on the ovaries that could give us some insights into why you're having infertility. Second test so that blood work and ultrasound on day 3, usually for testing. And then we'll also usually do a test to confirm that the fallopian tubes are open. That test is usually scheduled cycle days 5 through 12 in that window of time. So we talk about all that at the first visit in terms of what would be involved with the testing, and then a semen analysis for the male partner, assuming there is one, would also be performed. The other thing that we talk about at the first visit is doing a standard set of prenatal labs. And then we would talk to you about genetic carrier screening, which is optional testing to see if you're both carriers for the same recessive genetic condition. 5 minutes left. So genetic carrier screening would identify any genetic issues, and we would talk about whether you wanted that testing done. So really just a conversation at the first appointment. We would describe what testing would be recommended for you. We, again, may or may not be able to give you some insights into what's going on fertility-wise. I try to, guide patients as much as possible about what I think what I think might be going on based on history. But sometimes we don't know. We just need to wait for the testing to come back. After the testing comes back, we'll do a follow-up appointment and then review all of your test results and then decide on a treatment plan and a treatment approach at that point. So I'm going to take one more question because it's 7:55 and I'm sorry I didn't get to all of these. So last question that I'm seeing says, I'm 43 and a carrier for cystic fibrosis. What are my risk factors for passing this along? So cystic fibrosis is a recessive condition. So if you're a carrier for this, then you're not affected by cystic fibrosis. There is a 50-50 chance that you will pass on that gene to your child. So there is a 50-50 chance that they will also be carriers for cystic fibrosis, but would not be expected to be affected by cystic fibrosis unless your partner is also a carrier for cystic fibrosis. So it would be important for your partner to undergo screening for cystic fibrosis to ensure that they are not also a carrier. If they are also a carrier, then there is about a 25% chance that your child would have cystic fibrosis. We can decrease the chance of that happening by performing PGT testing of your embryos. We've talked a lot about PGT in this hour. We've mostly been talking about what's called PGT-A, which is chromosome screening. This is a different type of PGT. This is a PGT-M, which stands for monogenic allele. So cystic fibrosis is one gene. And if we test embryos, we would need to look very specifically at that one gene in your embryos, which we can do. It's an individualized test. So we need to usually develop the test that can take a couple of months to do and to get into place. But once we have that test, it's individualized to you. Then we can do IVF and we can test your embryos and then screen out embryos that would be expected to be affected with the disease and transfer embryos that don't have cystic fibrosis back to your uterus to try to make a pregnancy. That testing is pretty accurate. It's not 100%, but would dramatically reduce the risk of having a child with cystic fibrosis. Again, that's only assuming that both you and your partner are carriers for that disease. All right, I can take one more question. Let's see. What's the difference between using frozen eggs versus live? Does it make a difference in the likelihood of getting pregnant? So if you're referring to donor eggs, then in general, the frozen eggs do about the same as fresh eggs. There might be a slight benefit to live eggs or fresh eggs, but frozen eggs work pretty well these days. And the main advantage of using frozen eggs is that it's a less expensive process. It's also a lot faster because we already have the eggs available. And we don't have to recruit a donor and have them do the whole IVF cycle and do their screening. So in general, most of our patients who use donor eggs these days are using frozen eggs just because of the increased convenience. And again, it does perform pretty well in terms of outcomes and possible pregnancy rates. So I'm sorry I did not get to every single question here, but if you're my patient, obviously, hopefully we'll chat in person. If you're out there and you need help, again, please don't hesitate to make an appointment. I think our team put that, the information about how to do that. You can find us at bostonivf.com and then scheduling an appointment. You would usually call the 1-800 number, and that number is right on our website. So thank you for joining me today. I hope this has been helpful for some of you, and I hope that you all have a wonderful Thursday and be well. We'll talk to you soon.